Assalamualaikum everyone. Good afternoon. I am Dr. Mohammed Unair, resident of radiation oncology, and today we're going to discuss therapeutic radiation, its radiobiological background. Am I audible? So there are a few threshold concepts we need to understand before going into the topic, and we'll understand them first, and it will be easier for us to understand the topic. We'll start off with the biological structure of the malignant tumor. The smallest tumor that can be detected clinically or radiologically, or radiologically can be appreciated or can be seen with the naked eye, has at least a billion cells, 10 power 9 cells, and its weight is 1 gram, and its dimensions are 1 centimeter cube. This clinical range goes up to a trillion cells, 10 power 12 cells, and its size is 1 kg. So this is the clinical range in which we're dealing with the tumor. An example of this would be there might be a very slow growing, less aggressive tumor. It will maybe grow to a bigger size, closer to a kg, but a very aggressive tumor will generally be around this range. So this range goes up to 10 power 12 cells and has 1 kg in weight. This is the gross tumor. So suppose we have a patient of CA breast presents to us, and she has a clinical disease. We give her a cycle or 2 of chemotherapy. Within a few cycles, we see there is no gross disease. So now we have entered the microscopic territory. The patient has less than a billion cells. This is at least. And there would be about a million to a billion cells. This is the range, the clinical range. So a patient presents to us with a clinical disease. We give the patient chemotherapy, and then we have a clinical response. This is the clinical response, and if there is a pathological CR, there will be less than a million cells. This is important to know. So if even under microscope we're not able to appreciate a single cell, there might be at least a million cells in the tumor. This is very important to know. The next thing to know is the kickoff or accelerated repopulation time. This is the simple concept is that after treating the tumor, after a few days, most of the times after 21 days, there is an accelerated repopulation. This phenomena has been observed in different cancers. This is different for fast-growing tumors and different for slow-growing tumors. This is Wither's hockey stick. So Wither studies different head and neck tumors, and he saw that after 21 days there was an accelerated repopulation. This phenomenon was seen, and by calculating by the LQ model, linear quadratic model, this deproliferation comes out to be 0.46, and this study gave us this value to 0.6. There are different ways to calculate this. This is the easiest one to understand this. So what does this mean is after 21 days per day, 0.6 grays are wasted somehow. We have to add on this dose at the end. And this is a clinical application. So DANCA 6 and 7 trials were done, 66 gray in 33 fractions in 45 days with 5 fractions per week, which is what we do generally. It was compared with 66 grays in 33 fractions, but in 38 days, so 6 fractions per week. The dose is same, the fractions are same, but the treatment time has been reduced by a week. And what we see here is the deproliferation is 0.6 gray per day. So there is a difference of 7 days between these two arms, and there will be total gain in dose 0.6 into 7, 4.2 gray, roughly 6.5%, and it should clinically translate into an improvement of 12%. And this was the result. 6 fractions per week gave us 70% locoregional control versus 60% locoregional control. So now we have matched with the clinical data. The third thing we are going to discuss is the probability of cell killing or survival. So in an easier way to understand it, just suppose there are 100 balloons. Okay. So let's suppose we have 100 balloons here, and if we wanted to hit every single balloon, we need 100 rubber bullets. This is the ideal case scenario. Every bullet will hit every single balloon, and this is the hypothetical scenario we go with. But what happens is that as we're hitting, we get some hot spots. There are some points where more than one bullet will hit, and there are some spot will just, there are cold spots, there will be no dose given to those regions. And the concept of D naught is the dose, the mean lethal dose, which is capable of producing one lethal event per cell, but because of the random nature of cell hit, all cells are not killed, some cells survive. And this is the reason D naught gives us a survival fraction of 37%. Some of the radiation somehow wasted due to different cold and hot spots. So far we have discussed the biology of tumor, kickoff or accelerated repopulation time, and now D naught. D naught is the dose which reduces the initial survival initial fraction to 37%. What is D10? D10 is the dose which gives us one exponential or logarithmic kill. So 1000 cells, an exponential or logarithmic kills mean 90% of the tumors will be killed. So 90% of 1000 cells is 900 cells, 100 cells will survive. Again another D10, 90 cells will be killed because 90 is 90% of obviously 100 cells. Another D10 will give us 9 cells, and this will keep on going. The relationship between D naught and D10 is that D10 equals 2.3 into D naught, and we know the D naught for the mammalian cell is 2 gray. So this relationship gives us D10 for the mammalian cell 4.6 gray. Keep in mind that the D naught for different cells is different. For viral cells, it's actually 1500 grays. So the D10 for the viral cell would be in excess of 3200 grays. Maybe we attribute this to toxic. So this is a graph comparing these two things. This is for D naught and this is for D10. You start off with the initial number of cells and then you multiply it with 0.37 with every successive dose, and this is the number of cells left. And this is the same for D10. An important point to note here is that if a hypothetical tumor has 10 billion cells, so an exponential cell kill, which even kills 90% of the cells, it will still leave us with a billion cells, which is obviously a lot of cells. And continuing the stream of thoughts, two exponential cell kills will leave us with 100 million cells. Now, we'll go on to the historical basis of conventional fractionation. This is what Henry Coulthard did. So he was a French physician, and what he did was very genius what he did. Basically, the thought of carcinogenesis is spermatogenesis, because cancers are fast growing cells. We know that a high single dose of radiation can result in sterilization, but it also damages the skin around, which is the the skin of the scrotum. So their idea was that maybe we'll multiply the dose into smaller doses, which will again result in sterilization, but not damage the scrotal skin. I hope the thing is clear to you people. So looking at it again, we thought of carcinogenesis as analogous to spermatogenesis, and fractionated RT was given, which would result in cancer cell kill, and it would result with sparing of the normal tissues. How did he think about this? He thought that spermatogenesis can be stopped, sterilization can be done without damaging the ovary. And after doing experiments on different animals, rams, rabbits, the dose he was able to come up with was 2 gray. And this is the conventional dose we've been using for the last few years. So this was the French school of thought, Henry Coulthard, Claudius Ribot, and it showed that a ram's testis could be sterilized without causing major burns to the scrotal skin, which was opposite to the German school of thought. So far, we have discussed about the biology of tumor, D naught, kickoff time, and the history of the conventional dose. Now, linear quadratic model is said to be more than half the radiobiology we have to discuss the topic. First of all, just forget that tumor is written here. Just if you give radiation to a normal human, you can divide the cells into two major divisions: early reacting and late reacting. The first thing that doesn't make sense about this model is that it seems that there is a typo. It looks that it should be written early responding cells should be written here and late should be written here, because it looks clearly these are actually being killed with a lower dose. So why is late reactive tissue written here? So basically, it should be appropriately named as late responding but relatively radio resistant cells. Radio sensitive cells. But these are early responding but radio sensitive cells. So this is important to know. This is the first thing. So these cells will get killed by a higher dose, but they will react early. This is the first thing to know. The other thing about this is that early reactive tissues, these are the fast-growing cells, the cells of the mucosa or hematopoietic system. These cells are fast-growing, and radiation is an injury to the cell. So the major mode of coping with radiation injury for these cells is regeneration and repopulation. This is important for early responding tissues. But why for the late responding tissues, it's repair, not regeneration. And these cells are nervous system cells, kidney cells. So these are well differentiated cells. They don't have a lot of ability to regenerate. This is important to know. So this is the first thing. The second confusing thing about the linear quadratic model is that it says alpha d plus beta d squared. So alpha d is obviously at the lower dose, the linear component of the quadratic field, and beta is at the higher dose. So how come does alpha result in double strand breakage and beta, even being a higher dose, causes single strand? This was very confusing for me at least. So the idea here is that even though alpha is the lower dose, we will only consider those hits which end up with a cell kill. So at a lower dose, there is a lesser chance that a cell will be hit at this point, and another simultaneous radiation will hit at this point. The chance of this thing happening is very little at a lower dose. So at a lower dose, we only consider the alpha kill, which only results in a double strand kill. I hope this is clear to you. While at a higher dose, we have a higher probability that even though a radiation hits a cell at even a single point, then another radiation will hit at the analogous point of the DNA. Because the dose is higher, the probability is higher. So this is the second point, the confusing thing. Another thing to know about this is the alpha beta. So even though it might sound a bit reductionistic, but simply speaking, alpha beta is D0. It is the dose at which we start to get a significant amount of cell kill. So in linear quadratic model, we discussed about the early and late responding tissues, how they react to an injury, cellular injury, what is alpha and beta, and what is alpha beta ratio. Now we know that for late reacting tissues, the alpha beta is 3 gray, and for early reacting tissues, it is 10 grays. Now tumor is also a part of early reactive tissue. So in order to kill the tumor, we need to give about 10 grays. This is the thing we'll come across it, because alpha beta is the dose at which we start to get some sort of cell kill. But the problem is that late responding tissues have an alpha beta of 3 grays. So they will not be able to tolerate this dose. So if you are looking here, this is the point, there is a window. And at this point, we can see that due to what I said about the late responding tissues, they have a better way of repairing themselves. So at a lower dose, they're able to repair in a better way than early responding tissues. So there is a window of opportunity. And this window of opportunity is being used with the conventional radiation. And now going into the experiment we'll talk about, this early responding tissue can be seen as with the experiment Henry Coulthard did as spermatogenesis, and this is the normal scrotal skin. This was the same thing he did there, and this is the same thing we have been doing with conventional radiotherapy. So cancer cells do not repair at low doses, and the cell survival curve will be straighter for cancer cells at lower doses, which will provide us a window of opportunity at low dose. So this is the window of opportunity, and this is what we use in conventional RT. So finally, coming on to the topic we're here. Therapeutic ratio is defined as the ratio of tumor control probability to normal tissue complication probability. And above 1, a therapeutic ratio of above 1 indicates that overall the treatment modality is relatively more appropriate for the tumor control. and below 1 it means it is more toxic. So think of it just as the therapeutic window we study in pharmacology for different drugs. And we remember, the bigger the therapeutic window is, the better the drug is to use. So tumor control probability is this thing and this is the normal tissue complication probability. The TCP curve should be to the left as much as we can have, and the NTCP curve should be on the right side. So if the tumor control probability is at least 50% and normal tissue complication probability is less than 5%, then we think that the radiation plan is proper. While if obviously there is less than 50% chance of tumor control probability and more than 5% chance of normal tissue complication probability, we obviously will not accept the plan. This is another representation of these things. So to move this graph here, we have different ways to move this graph here. We have different ways to do the description. There are different ways to define the therapeutic ratio. There is LKV model, which is formula this, and then the physicist people, they do this, they divide these all the GTVs into small boxes, and they calculate the TCB in every one of those, and then they add the tumor control probability. And then there is another formula of TCP, which is double exponential of survival fraction. So we'll use on the easiest one to understand our things. So remember what I told you about the biological structure of the tumor. At least 1 billion cells mean a clinically a cell which can be clinically seen. So TCP, tumor control probability, equals E, which is the natural logarithm, minus n. N is the number of clonogenic cells. A clonogenic cell is the single cell which has the ability to form a new cancer cell. So let's just say we started off with 1 billion cells and we gave certain different logarithmic doses to the tumor, and we're only left with 2 cells, 2 clonogens, 2 cells which are able to divide into a whole new tumor. So TCP will be E over minus 2, because these are the number of clonogens, and is the number of clonogens. But the tumor control probability is only 10%. So even if we started off with 1 billion cells and we're left with 2 cells, the tumor control probability is only 10%. Why? If 1 cell survives, the TCP will increase to 37%. Not a significant increase for the patient. But all of a sudden, when 0.1 cell survives, the TCP increases to 90%. So for starters, how can a patient have 0.1 cells? This is not possible. A patient will have a cancer cell or not. So this is the dose we calculate that 10 patients will have a single cell. We increase the dose in our calculations. And if we want to increase the tumor control probability to 99%, well, we can make it to 0.01. 1 cancer cell per 100 patients. And one thing I wanted to show you people is that this is the TCP curve is S-shaped, as you've seen, and this explains sudden increase in tumor control probability. With one logarithmic cell kill, the tumor control probability increases out. So a question is that a patient has 1 centimeter cube tumor, which so at the start it has 1 billion cells, 10.9 cells, and how much radiation in 2 gray per fraction is to be delivered to achieve a 90% tumor control probability. We know that for 90% tumor control probability we need 0.1 cells to survive. So 10 power 9 cells, we need 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 logarithmic cell kills to take this number of cells from 10 power 9 billion to 0.1 cells. And at the start we calculated that the D term for 1 million cell is 2 grade, 2.3, 4.6 grade. So the number of log reductions per 90% tumor control probability is 10, and this dose will be 4.6 grade for 1 logarithmic cell kill, and 4.6 grade for 1 logarithmic cell kill, and 46 grade 10 fraction for all these. So isofactor dose with 2 gray or the EQD2 will be generally calculated. Putting in the value D2 is the dose we want to calculate, and D2 is the 2 gray per fraction. These are the values alpha beta for the tumor is 10, 4.6 gray per fraction, total dose 46 gray. and we come up with 56 gray with 2 fractions to be given in 28 fractions in 38 days. And at the start we discussed about the deproliferation. So after 21 days, 26 grays go to waste. So we have to account for these now. And this means 7 days into 0.6, 10 gray. 10 gray has to be added. So it comes out to be 66 gray, 33 fractions in 38 days. Well, if the patient has microscopic disease, again we want to achieve 90% tumor control probability. For 90% tumor control probability, the patient has 10 power minus 1 cells, 0.1 cells. Again, we said that for microscopic disease, there will be from a billion or from a million to a billion cells. So we'll start off with hypothetically 10 power 7 cells. Again, we need 8 logarithmic cell kills. And this is the formula. Putting in the values 2.3 into D, 4.3 gray for 1 logarithmic cell kill. For 8 logarithmic cell kill, it's 36.8 gray and 8 fraction for 4.6 gray per fraction. Calculating the isofactor dose, will come up with the dose 44.8 gray with 2 fractions to be given in 22 fractions in 30 days. Again, deproliferation 0.6 into 9, 5.4 gray. TCB of 90% will be 50.2 gray in 25 fractions. So the clinical experience that we have had for the last 100 years somehow matches up with the linear quadratic model. And again, the tumor control probability for microscopic metastasis, if 100 patients are treated, we get a 15% failure in that. The reason is simply the number of clonogenic cells or initially the size of the tumor. We know that the bigger the size of the tumor, the more will be the number of tumor cells and the higher will be the logarithmic dose needed to be. So looking at this, if we want to achieve 90% tumor control probability in a tumor with a billion cells, we need to give 66. But the same dose will give us more or less 40% tumor control probability if a tumor has a 10 billion cells and almost 0% for a gross tumor. So radiation dose is different to different zones. I think this is rather clear to you people by now that the tumor burden is different for different cells. This is again showing the TCP directly proportional, inversely proportional to the number of clonogenic cells. This obviously makes sense. The lesser the number of clonogenic cells, the lesser will be the probability of the tumor to recur. So radiation dose different regions is that 60 gray is given to high tumor burden disease because of the microscopic disease and 50 gray is given to the low burden disease. So summing up everything we have seen, 1 kg means a trillion cells up to 1 gram, which is a billion cells. This is the clinical range. To treat a patient who are unable to see the disease radiologically or clinically, now the number of tumor cells will be between 10 power 6 to 10 power 9 cells. This is the point of pathological CR. And below this, we can have a million cells, but we will not be able to appreciate them under the microscope. And this goes down. And looking here, the tumor control probability, there is a sharp increase here. Look at this. The total dose is 60 gray, tumor control probability is 37%. All of a sudden, with one algorithm which we saw before, the tumor control probability goes up. So this is a function of probability. So we know the basics of the tumor control probability. Now we'll discuss how to increase the tumor control probability. We can either do this by pulling this side of the graph, TCP to the left side, or moving NTCP to the right side. First we'll look into the TCP. So how can we get tumor radiosensitization? By fractionation of radiation sensitizers. And there's a different way fractionation. In radiosensitizers we have hyperbaric oxygen, hypoxic cell sensitizers and hypothermia. So we'll start off with the trial EORTC 22791. In head and neck, conventional fractionation was done with 70 gray and 2 gray per fraction in 7 weeks versus hyperfractionated. 80 gray in 1.15 gray per dose and 2 doses were given per day. 6 was apart for 7 weeks. calculating the BED for the conventional fraction radiation, the BED turned out to be 84 grade 10. The 10 means because tumors are only reactive, we're calculating the BED for tumor cells. So for conventional fractionation, it was 84 grade. For hyperfractionated regimen, again putting in the values 1.15 grade per fraction, it is 89.8. So for the conventional, it was 84 and it is 89.8 for hyperfractionated. It should be more damaging to the tumor. So the difference of 5.3 grade BD should translate into 10 to 20% increase in the tumor control probability. And this is the result of a trial. There was a 19% gain between the hyperfractionated and conventional regimen. Then this first thing we discussed is hyperfractionation, and then we go on to chemosensitization, CCRT. So this is a meta-analysis of chemotherapy in head and neck, an update of 93 RCTs with 17,000 patients. So in head and neck cancers, RT alone was compared with CCRT, which we generally do in head and neck cancer. There was a difference of 13% of local control at 5 years. So hyperfractionation and CCRT almost gave the same result. Next, going on to radiation sensitizers. Hypoxia is a well-known determinant of radio resistance, and many strategies have been developed to cope with hypoxia. An easy way to think about this is that viral and bacterial cells obviously don't use oxygen, and their D naught is very high. Viral cell has a D naught of 1500 degrees, so there might be something going on with oxygen and hypoxia and cell kill. So different ways have been used to radiosensitize the tumors cells. So transfusions are the oldest way of oxygen modifying therapy, and then hyperbaric oxygen has also been used. Blood transfusions have been used before RT, and the through-potent trial actually showed negative correlation between HbA and survival control, but one Canadian retrospective study of cervical cancer showed positive outcome in blood transfusions if hemoglobin level is kept above 11, which we know is a prognostic factor for cervical cancer. The next is hyperbaric oxidation for tumor sensitization. So this is a Cochrane review, and it saw that there was an overall reduction in risk of dying, but with significant increase in injury. This was radiation induced, and there was an increased chance of seizure. And another thing was that the advantage was compared when the patients were hyperfractionated. So hyperfractionated radiotherapy gives us a better response due to the higher dose per RT. So the jury is out there, but generally we don't use hyperbaric oxygen therapy. So this is the graph showing that this is written favors HP or hyperbaric oxygen therapy. So clinical response, it favors hyperbaric oxygen therapy, but the side effects were not favorable. These are different randomized trials, and they have been tried for different cancers for hyperbaric oxygen. Majority of the trials are positive, but generally it is said that hyperbaric oxygen therapy is very cumbersome and there are associated side effects. The next type of radiation sensitizers are hypoxic cell radiosensitizers. So nitroimidazoles mimic oxygen in fixed limit. So remember, radiation damages DNA and the DNA repairs obviously. Oxygen does what oxygen does, it attaches to the end of the DNA strand. So the repair cannot be done. New bases cannot be attached. So this is called fixation. So these drugs are mimicking oxygen. This is the same mechanism for oxygen, and this is the same mechanism for these sensitizers. These are the different drugs, and the morazole has been used. So this is an RCT of supraglottic pharyngeal carcinoma. Its name is NACA-5 trial. Patients were randomized into RT plus morazole and RT plus placebo. And the local regional control was better for the morazole patient, 16% improvement. While the disease-specific survival was also better for the patients who received the morazole with RT. A meta-analysis with 91 RCTs and 11,000 patients showed an improved local regional response with an odds ratio of 0.78, and overall survival was also improved. This strategy is the standard of care in Denmark, but it has not been used due to different side effects, and it has not been accepted by the majority. The next one is bioreductive drugs. So these drugs are themselves damaging to the hypoxic cells, and tumor cells are hypoxic. So tirapazamine is a drug, and different phase 1 and 2 trials were done for different cancers which showed very good responses. But a phase 3 trial was done which randomized the patients into two groups. CCRT versus CCRT with cisplatin and tirapazamine with the primary endpoint of overall survival. So 861 patients were accrued and the overall survival was 65% for concurrent chemoradiotherapy and 66%. So there was no significant difference between these two groups. Now we have for radiation sensitization we have discussed about hyperfractionation, oxygen and different drugs. And finally we're moving on to hypothermia. So hypothermia, what it simply does is it decreases the alpha beta of the T. So we thought of alpha beta as the T naught, the dose at which we start to get a significant cell kill. So if hypothermia decreases the alpha beta, it will obviously increase the cell kill. This approach is being used in a lot of Indian hospitals. This is a meta-analysis and systemic review of hypothermia and radiotherapy in head and neck cancers. And the forest plot shows there is the forest plot favors RT plus the hypothermia, and the side effects are actually comparable. So there is not a significant increase in side effects. The local tumor control is very better in hypothermia. And this is another meta-analysis for cervical cancer, hypothermia and radiotherapy for advanced cervical cancer. And again, the forest plot favors hypothermia plus RT. And this graph shows the local control. This is showing the complete response. So hypothermia is a modality which I think can be used in the low middle income countries because this is relatively not a very expensive form of treatment. It can be used. So we have discussed how to increase the therapeutic ratio by moving the TCP curve towards the left. Now we will discuss about how to move the normal tissue complication probability to the right side. How can we decrease that? Again, we'll use the last example, URTC 22791. So this is the trial we discussed with hyperfractionation. So for hyperfractionated RT, the BED was, for late effects, we use late effects for the side effects to the normal tissues. For hyperfractionated regimen, it is 116, but for conventional RT, it was 116 gray, the BED. So it means it will be less damaging to the tumor tissue. So this is the clear-cut radiological basis for hyperfractionation causing less side effects. And fractionation has been used since the early days of radiation oncology. Another example of this is the hyperfractionation in pediatric brains. For example, we are going to radiate a child with a brain tumor because the alpha beta of the brain is 3, so we don't want to damage it. So we hyperfractionate in pediatric brain tumors. Another counterintuitive example to understand this is we generally give 30 gray pen fractions in pediatric setting. So it doesn't make sense because the alpha beta of the brain is 3. Why are we giving 3 gray per fraction? Well, the brain will be damaged, but it is a late-lying tissue. The patient doesn't have that much time to live. The survival is not that, so the patient will have a better response. Radioprotectors are also used, and the only FDA approved radioprotector is amifostine. The mechanism of action is that it needs alkaline phosphatase to activate, and cancer cells lack alkaline phosphatase, and it spares the cell from radiation damage. So IMRT is intensity modulated radiation therapy, and beams are carefully customized to result in a non-uniform intensity. So this is an example to understand. This is prostate being radiated, and this is the OR, the rectum. So in case of a linear accelerator, this is the photon. This is the penumbra, the certain fall off of the dose, and we want to give the least dose to this area. So this ray is obviously giving the least amount of dose to this region of our OAR. This is also giving the least amount of dose, but this range even maximum goes to our OMR. What IMRT does is, as the name says, intensity modulated. So the dose has been modulated in this region. So this is the dose intensity. It is decreased in this region, and there is least amount of dose delivered to the OR, and these regions will obviously less to the OR. So this is the basic principle for IMRT. This is the treatment plan for head and neck cancer, and we can see that the carotid is being covered. But with IMRT, we can get non-linear planning, and the carotid is spared, and the patient will have spared salivatory function. So going back to the start of the linear quadratic model we discussed at the start, there was that window of opportunity. But the case there was that normal tissues and tumor tissues are getting the same dose. But with IMRT, the dose delivered to the normal cells is very less. So our window of opportunity actually increases. Even with a 20% geometrical sparing, the window of opportunity has increased a lot. It has gone up to 10 grades. And with the application of overall time, this is a better way to understand this. For a non-IMRT plan, low burden disease gets 50 gram, high burden disease gets 60 gram, gross disease gets 70 gram. But in IMRT, the low burden disease gets 56 gram. The gross disease gets 70 gram, but the high burden disease gets 63 grams. Why is that? Again, in the first 5 weeks, we treat all these regions with 50 grams, and then this region gets 70 grams in 7 weeks, and this region gets 60 grams in 6 weeks. So, this first concept we saw at the start, deproliferation. In IMRT, this dose has to be increased because these regions get their dose in 7 weeks, so we have to end up the dose. IGRT is the image guided radiation therapy, in which imaging is done at the time of the treatment. So we get a reference images, and preferably daily an image is taken, and we compare these two, synchronize these two images, and then we perform RT. This is an example of two images taken. Now they're synchronized. This is a French trial that is comparing daily versus weekly prostate cancer, IGRT. And the basic idea about IGRT is decreasing the size of the liver. And this is the tissue toxicity. It has been halved in the daily IGRT. So preferably we want the 3D CRT to be basically. And finally, immunotherapy and radiation therapy. This is the unicorn. Everyone seems to be doing it nowadays. So for stage 3 non-small cell lung cancer, post CCRT, patients were randomized into durvalumab versus placebo. And we can look at the probability of overall survival at 40 months. There is a significant difference. There is a significant separation between these two things. The overall survival was 66% for durvalumab group compared with 55% for the placebo. So how do we explain this? And abscopal effect phenomena is used to explain this effect. What happens is that radiation causes apoptosis in the cancer cells, and these dying cells, well, tumor-associated antigens are taken by the antigen-presenting cells to the T cells, and then tumor-specific T cells go out and damage the cancer cell. This is another diagram to show that RT causes release of cancer cell antigens, and APCs present these cancer antigens, and then T cells are primed, and these T cells are taken to the tumor